So, I know you've been here a week or so now, but this is the first time we've gotten to work together. So tell me, how's it going? Are you enjoying yourself?
It's okay, I guess.
What rotations have you done so far?
Just surgery.
Do you have any special interests? Do you know what you want to do?
I really want to go into ortho. I really enjoyed that part of general surgery with the trauma and seeing people get better. Wish I had more time there.
Well, I'm sure we can find some things that will interest you here too. So let's get to your presentation. I'd like for you to present this case in 2 to 3 minutes. Stick to the pertinent positives. Begin with the chief complaint, past medical history, social history, then go on to the physical exam, pertinent laboratory findings, and x-rays. Then you can summarize the case with your assessment and plan. Can you do that?
Sure.
Great. Well, let's see what you've got.
This is an 89-year-old white male who had a sudden onset of difficulty with his balance approximately 6 to 7 months ago. He says he never had any difficulty with his walking, never had any falls until about 6 months ago when he fell while walking. But he's 89, so I'm sure he's not all that steady. Says he doesn't lose consciousness, denies hitting his head, denies ever having any loss of consciousness.
This is Bill Atwater. That's all he's had to say about his fall. He's usually a very good historian. I've known him for many years.
Well, I mean, he might have said something about stubbing his toe, and being with his grandson or his daughter. I don't really know. I mean, I wasn't really listening. He just went on and on and on. You know how much can you really trust when he's that old? I mean, he denied any history of head trauma. He denied any history of peripheral neuropathies, seizures, or other neurological disorders. He denies any history of strokes or hypertension. There's no change in his eyesight, though he should probably be checked out by an optometrist because of his age. He does wear hearing aids. He's had them for about, I guess, 3 months. Yeah, no change, or no recent chest pains, no palpitations or syncope, no arthritic complaints, no joint or muscle abnormalities. He's got a cane now, but he should probably have had one a long time ago. On physical examination, he's an 89-year-old white male in no apparent distress. Blood pressure 136/80, pulse of 68 in regulars. Temperature is 98.6, weight is 164 pounds, pupils are equal and reactive to light, extraocular eye movements are intact, there's no scleral icterus, no conjunctivitis, there's no nystagmus, his ears are clear, he has bilateral hearing aids, there are no carotid bruits, heart is regular in rate and rhythm with no murmurs or gallops. Pulses are good in his dorsalis pedis and posterior tibial and his lower extremities, as well as his radials and his upper extremities. The patient has had recent falls and imbalance, especially problems at night, which suggests possibility of posterior column disease versus strokes or other central nervous system pathology. When I was in ortho, they talked about old ladies getting cervical compression fractures just from stepping off curbs because of osteoporosis. I guess old guys can get it too, but I suppose we should get an x-ray to check them out. So in addition, I'd get an MRI with or without contrast to rule out any strokes.
Okay, well, first of all, it seems to me that you've really focused your thinking on mechanical problems related to balance and falls.
Well, I mean, I'm just coming off of surgery, so,
Yes, but even on surgery, you have to consider a broader range of differentials so you don't miss something essential or submit your patients to unnecessary procedures. We're going to go back in and see them together. Not right at this minute. In fact, I'd prefer if you weren't sitting above me when we're talking. Thank you. We're going to go back in and see them together, and we can discuss some other possibilities in your differential diagnosis. But before we do that, I want to talk to you about your presentation.
Okay.
I'm worried about some of the language that you used. You said several things about older people that seemed to me kind of disparaging, and I want you to be careful about any prejudice or ageist attitudes. And by prejudice, I mean any prejudgment of people.
I'm not prejudiced, but you know how old people are.
I just want you to be aware of any ageist language or attitudes and that that's not appropriate.
Okay, sure.
You know, even though you may think that this has nothing to do with orthopedics, your patients are going to have severe limitations to deal with after surgery. And you are going to be expected to come up with plans that are reasonable for those limitations. Even though here our patients' limitations are due to their age and declining health, we likewise need to be aware of what's going on so we can develop appropriate plans. Do you have anything about Mr. Atwater's living situation and social history that you can tell me about?
I think he lives with his son, but I guess he's doing okay because he still drives and he does yard work. He's noticed some difficulty with his balance, so he's been using a cane for a while. It's particularly worse at night if he tries to get up and go to the bathroom without turning on the lights. Hey man. Yeah. Yeah? No way. Yeah. Okay, well look, I'm in the middle of this thing, so let me call you back in like 10 minutes? Alright? Okay, yeah. Yeah. Alright, bye. Yeah, okay. Like I was saying,
That was very disruptive. Would you please turn off your phone until we finish rounds? We only have a short time together and others can handle emergencies. Let's not be interrupted again.
okay.